I'm Duncan Law. I'm the clinical lead for the London South East Learning Collaborative. Alex and I are going to do a bit of an introduction. For some of you, this will be stuff you know already. For others, it will be brand new. And for some, you might think you know this, but there might be some surprises in there. So apologies if we're repeating stuff that you already know. Never does any harm to remind people of stuff. So we're going to talk about what CYP IAPT is. This is the bit that you may know, or may be a surprise. The really important thing to remember is that CYP IAPT is simply a set of principles, a set of ideas for what will improve services. We are all struggling with services that are massively under-resourced for the demand that's out there, and we need to make sure that the resource that we have, the limited resource that we have, is focused and targeted in the best possible way to have the best impact with the kids that are seen in services. The government language is to talk about transformation, but really this is about service improvement. It's not taking services from one place and making them completely different. It's about building on the good work that's already happening within services and to make them better than they are now, to continuously improve services for the benefit of children and young people. The principles are intertwined and complementary, and I will go through these one at a time, so don't worry about understanding that slide there. So here they are. First one is about participation, and this is about amplifying the voices of children and young people who use our services and the parents of those children in order to make sure that the services that we're changing are changing in line with the way that will make them more accessible and acceptable to the children and people that we're aiming the services at. And the only way we can do that is by talking and listening and by being influenced by children and young people. Next one is around increasing awareness. So we know that the majority of children who have a mental health problem don't come close to child mental health services, don't come anywhere near a child mental health professional. Part of that is the limited resource. But that's not the only part of the picture. A large part of it is that children and people and the adults around them don't recognise mental health problems. They're often misidentified as difficult kids or ignored because it's the quiet kid that sits at the back of the class not making any trouble. Increasing awareness in the wider community about what a mental health problem looks like, and for children and their parents themselves as well. Increased awareness makes more people likely to come forward. And the other side of that coin is decreasing stigma. So even if a young person or a parent knows that their child has a mental health issue, sometimes the stigma of admitting that stops people coming forward and engaging with services that may be helpful to them. Those things together make services more accessible and acceptable to the children and young people to which services are aimed. And the other element of IAPT is to try and continue to make services as accessible as possible. And one of the themes is about introducing self-referrals as much as that's possible within services. And it's also about making services transparent and accountable. For those of you who have read Future in Mind and the 5-year forward mental health task force view, I'm not saying you should have done, but it's helpful, it's good reading, because this is the policy that's driving all mental health services across health and education. So Future in Mind is the policy that's driving all implementation. One of the things that it says in there really clearly is that services should be accountable and transparent. One of the things that the task force says is that there's a black hole of data in mental health. We don't know and we can't demonstrate how effective our services are. And one of the big drivers through CYP IAPT is to change that, to be able to show that services are making a difference to young people's lives. If they're not, then we need to change things. If they are, then we really need to demonstrate and shout about that and celebrate it, because it's showing the difference that services make, which is likely to, well, at worst, keep hold of the money that we've already got. If we don't show the impact that we're doing, that money will disappear. And if we do show the impact, we can also then start shouting and saying, and if you give us more money, we can demonstrate an even bigger impact on children's mental health. Important part of the delivery, and this is what a large part of this afternoon is going to be about, is around introducing evidence-based practice. So making sure that the interventions that are being delivered in services are the ones that are more likely to work. We know there's growing evidence base for some interventions which are more likely to work with certain kinds of kids and certain presenting difficulties than others. We should be making sure that we are providing or have the capacity to provide those services where they fit with the child and young person themselves and the unique context that they're in. And there's a big theme that runs through all this, which is about better collaborative practice and shared decision making. So making sure that as clinicians, or if you're a manager, making sure that the clinicians that you manage are working in a context which is about understanding and listening to children and young people about what they want to change about their lives, not what we as professionals feel they ought to change, but what they want to change, and drawing in interventions that are likely to work with that child to help them make the changes that they want to make. If you put all those principles together, you get something that looks like this, that they are intertwined and complementary. And if you put it into a clinical context, you get something that looks like this. So you have the research evidence, so the stuff that we know is more likely to work in certain contexts than others. But that's not enough on its own, far from enough on its own. It's not about wholesale implementation of nice guidelines. It's a misconception that if you just apply manualised approaches to mental health services that you get better outcomes. That's not necessarily the case. What you need to do is a combination of a few things. So you need to know what the evidence base is, and you need to be able to draw on it, but that needs to be combined with the goals and wishes and the unique context of the child or young person or family that you're working with. The clinical skill, the really important bit in all this, is putting both these bits together. So understanding the research evidence and knowing how to apply it, understanding what the goals and wishes and the unique context of the young person is, and coming up with a shared and agreed formulation, a shared understanding of what the problem is and a way of tackling it which both draws on the evidence base and fits with the context of the child. And it's the clinical bit that's the really difficult, sophisticated bit to do. And once you've got that, throughout the course of an intervention, you can set up feedback loops between the family or young person and the clinician to make sure that, although you might be sure you've started in the right place, that actually you're continuing down the line which is useful to the child and fits with the kind of clinical direction that you and the young person wanted to go in. So all those principles of IAPT kind of fit within this, about better collaborative practice, about outcomes monitoring, about drawing on the evidence, about applying evidence-based practice. So that's what it is. I'm going to hand over to Alex.
So now you know what CYP IAPT is as a program of transformation. You're probably thinking, where are we going? And if you're not, you could be now. So in terms of coverage across the country, we started off in 2011, and there are now 6 learning collaboratives like this one across the country. The most recent one, added in blue, is the collaborative in Derby. So at the moment we cover 80% of the country, or at least 80% of the 0 to 19 population. And we have a target to cover the whole of the country by 2018, the end of 2018. In terms of how CYP IAPT fits into the bigger picture and within many other initiatives that are underway, it looks a bit like this. We could zoom out a lot. There are lots of other initiatives that it works very closely with and goes hand in hand with. Perhaps most importantly, in terms of policy, there's a huge gamut of drivers at the moment that means that CYP IAPT has to happen. As Duncan said, it's key to Future in Mind and the 5-year forward view for mental health. which means it's a core component of the local transformation plans, which in turn are being drawn into the sustainability and transformation plans. And it's also now, and this is very important from the point of view of any clinical commissioning groups, part of their improvement and assessment framework. It's one of the key indicators. So this is very good for us. This service transformation must happen. So what does the collaborative do to enable this service transformation? We simply input into the system at many different levels. This is just a very small cross-section of what we do. We use a range of markers and indicators, values and standards to help services track their progress, and in turn this helps us gauge where they're at, where they're doing really well, and perhaps where they're doing less well, and we can offer some kind of intervention. And we also share this data with Health Education England and NHS England, our funders, and your funders. We provide ongoing consultation and support. This might be in the form of coaching to service leads and managers to help them through the really knotty strategic problems within their organisations and the wider system. CYP IAPT is about transforming whole systems across the NHS, across local authorities, across the voluntary sector. We put on events that function as platforms to share best practice and learning, and we gather all that up and we communicate it to the rest of the Learning Collaborative and further afield as well. If you have a look at our website, there's lots of evidence of this happening, and our YouTube channel, where the videos from this event will be housed. We work very closely with services to co-produce whole team trainings, so that what we delivered is really tailored to the needs of services. And we work with them to, where systems are struggling, we will deliver action learning sets and offer peer supervision. And finally, what you've come here for is the trainings and evidence-based interventions. So I'm going to say very briefly how you'll be able to access these trainings. And on your tables, you'll also find a piece of paper that looks a bit like this one, with the timeline on, which will tell you in enough detail what you need to know and when you need to do those things in order to apply for the trainings. So at the moment, the offer to services is that we can guarantee that each service or each partnership can have 3 training places for the therapy trainings, as long as we receive applications by the end of July, and that the applications are from candidates who are suitable. You will see also the leaflets on your table that go into some detail about each of the courses that we offer, and explains the criteria for any candidate wanting to access those courses. And just to remind you as well that these courses are completely free. The actual trainings are paid for by Health Education England, and then NHS England will even give your services for therapy trainees 30k to cover the cost of someone filling your time whilst you're doing the course, and for supervision trainings it's 20k. We will be accepting applications after the deadline of the 31st of July, but they won't be guaranteed places. So just remember that. And in terms of finding backfill, some of you may know that locating someone to backfill your role will take at least 3 months. So the sooner you and your service get that sorted out, the better it's going to be come January 2017 when you start training. So in terms of actually accessing a place from your point of view, I know a lot of you have already made an expression of interest, which is the first step. But if you haven't, then you absolutely need to do that to be considered for a training place. Once we receive your expression of interest, if we've already had it, we will send you an email by the end of the week saying, do you still want to do this training? And if you say yes, we will then send you a link to the online application portal, which you absolutely have to complete. This will be with either UCL or King's College London. And there will also be a link to an online checklist. There will be 2 checklists we need you to complete. One will be a modality-specific checklist. It basically goes through the sort of things that need to be committed to in order to support you to do your training as well. And there's also a service level checklist, which is about what needs to happen at the service level to support anyone doing the training. So in order for your applications to be considered, we need both of those things to be completed, a formal application and both of the checklists. And all of this, again, is in this document on your tables with the timeline. And just to cover the timeline, again, so today the application portal opens, which is definitely cause for celebration. This is why we have cake downstairs. And we would like your applications to be in by the 31st of July. By October, the memorandums of understanding should be signed off between NHS England and your partnerships, or your CCGs actually. And these will finalise the numbers of training places your partnerships will be taking, and also the amount of funding which will go to the CCG to then be drawn down by your service in order for them to backfill you. So that should happen in October, and now you can see why we need to get these training places confirmed as soon as possible. Then supervision and service leadership training start in November, and the therapy training courses start in January 2017. Before all of that happens, too, we also have a launch event on the 21st of October, and for anyone who's going to be doing a training this coming year, that launch event is completely mandatory, but it will also be a lot of fun. Okay.
I just need to say something very quickly. So, I just need to say one other thing, following on from Alex. And this is on behalf of Peter Fugel and Derek Bolton, who are the AGI leads, university leads for the programme. And this is to say that in previous years, the courses have been run effectively, you've been out of service, or well, the course has been a 2-day teaching and then a day and a half back in service practicing what you've been learning. We've had feedback from collaboratives, from partnerships previously to say, actually, that's hard for part-time people to access, and the courses are very intense, and getting everything you need to do within a year is it's quite a demand on people. So for those reasons and other reasons, we've moved to extend the training over 2 years. So it'll effectively be a day's teaching plus, well, it works out on average 3/4 of a day practicing what you've learned in your place of work. And the reason for this is to make sure that the learning is embedded over 2 years and to make it more accessible, as you said.